Welcome, everyone. My name is Hannah Stone, and I work in marketing and communications, outreach and engagement at the University of Iowa Healthcare. Thank you for joining us in this evening for our Meet the Midwives webinar. You'll hear from our experts on our nurse midwife team shortly. Before we begin the program, I have a few logistics to share to make for a great virtual experience. This program is hosted in a webinar format, meaning you will only be able to see our UI Healthcare speakers on your screen. In the upper right-hand corner of the screen, you have a few options to change your view of the speaker and the presentation. At the bottom of your screen, you can click the Q&A button to submit a question for our speakers at any time during the program. When answering your question, you can choose to submit your question anonymously. We will also be addressing questions that were pre-submitted upon your registration throughout the program. Closed captioning is enabled, and you can choose to turn that on by using the Closed Captions or CC button at the bottom of your screen. You can adjust the size and placement of the closed captions on your screen with the button. Without further ado, we will begin tonight's program. I will now turn it over to our nurse midwife team.
Thank you so much for that warm welcome, and thank you everybody for joining us tonight for one of our quarterly Meet the Midwives webinar, where we get to boast a little bit about the midwives at the University of Iowa and give you an opportunity to meet all of us. We realize that we're getting to be a big group, and so we want you to have the opportunity to meet somebody who may be able to be a part of your birthday party, or if you are considering having a midwife, to let you know all the things that the midwives may have to offer. I wanted you all to know that we are now servicing 6 different outpatient clinic locations, including Cedar Rapids, Washington, Muscatine, and then locally in the Iowa City area at Iowa River Landing, where we offer evening clinic appointment times, the main campus, as well as our North Dodge location. We are delivering babies at what we call MCU, or Medical Center University, which is the big house on Hawkins Drive. We also do births at our downtown campus, which is formerly known as Mercy. So we are really excited to get to serve the community. Next, I'm just going to go around the midwives and do brief introductions in alphabetical order by first name. And I just want each midwife to say their name, talk about any areas of interest, and then your favorite thing about being a midwife. And in alphabetical order, our first midwife is actually now Abby, Abby Knutson. She couldn't join us tonight, but she is one of our newest midwives. And I should mention, since we're staffing 2 units, we often have midwives that are tied up for these events, and plus the evening clinic. So everybody tries to make it, but Abby couldn't make it tonight. And you'll be seeing her around, though, hopefully. And then again, I'm Amber Goodrich. I've been at the university for about 5 years now. I really love everything about being a midwife. But when I was in private practice, I did a lot of infertility workup and have carried some of that over to Iowa. And then I really have the privilege of being able to refer people right in our own backyard if they need more help with infertility to our reproductive endocrinology clinic. But I would say probably my favorite thing about being a midwife is being able to follow a person through contraception to having a baby to annual exams, and then through perimenopause and beyond. So I really like establishing that relationship with the people I serve. Andrina, I see you were able to sneak away from labor and delivery.
Hi, everyone. I'm Andrina. I've been with the university a little over 2.5 years. I really am passionate about vaginal birth, just that in general, just being in labor and delivery. I've really, over being in clinic for the last couple of years, have really started to realize that I really like contraception, especially in the teenage population. Prior to coming here, I worked also in mental health, and so I really have interest and a passion in postpartum anxiety and depression, and helping people understand that that is definitely something that is important to talk about and to feel safe in doing that. I work in the Washington Outreach Clinic every other Friday, and then also I work at the North Dodge Clinic.
Thank you, Andrina. Next, Becky Winnicky.
I'm Becky Winnicky, and I've been a midwife for almost 25 years. I think I like all of my job, but the thing I have liked the most is starting to see young women when they're teenagers and helping to empower them to take charge of their health and see how they've matured and grown every year when they come back to see us. And I've done this for so long that I have actually delivered babies now for a lot of people that I delivered when I started out as a young midwife. So that's always very exciting as well.
Thanks, Becky. Bree Herring.
Hi, my name is Bree. I've been a midwife here at the university since early 2022, but I've been a midwife here in the state of Iowa since 2012. I staff a couple of different clinics. I go to IRL, and then I also go to our Cedar Rapids outreach clinic. If that's a convenient location for anyone, it's kind of an awesome little space. I love a lot of different things about being a midwife. I think if you don't have passion for this job, you don't stay in it for very long. So there's just like a ton to like. I really enjoy, obviously, the baby catching. That's the highlight for every single one of us, I'm sure. But I also really love kind of all things education. So whether that's educating patients on different interventions, different things that they can pick, or just that they didn't really have a lot of information about prior to coming to see the midwives for the pregnancy. I really love it when you can kind of help somebody understand recommendations and connect those dots. And then I also really enjoy educating our nurse midwife students as well and watching them really be able to jump in and kind of help take charge of caring for our patients. It's really fun.
Thanks, Bree. Yeah, little plug. We did just start our very first cohort a year ago of the nurse midwifery education program, which is the first ever nurse midwifery education program in Iowa. So we're super excited to help be a part of creating more midwives. And Bree is the assistant program director in that program. Christina Shutters is up next, but she wasn't able to make it tonight. Christina and Megan Dre and Sarah Jones are all kind of unique in that they work 50% in the high risk OB clinic, and then they also take labor and delivery call like within the midwife cohort. So it's really unique that we're able to still offer some midwifery care in the high risk OB clinic. Next is Elizabeth Cook.
I'm Elizabeth. I've been a certified professional midwife for 19 years, certified nurse midwife for 15 years. Of that, I've been at the university here for about 3.5 years, most recently just working labor and delivery at our new downtown campus and loving that. I love the birthday parties, but I really love the privilege of being with families during some of the most intimate moments of life and sharing that journey with them. So welcome.
Thanks, Elizabeth. And then Jackie Roman also couldn't make it tonight, but she is another one of our certified nurse midwives. A few of our midwives, including Jackie, are unique in that they're skilled in also colposcopy, so doing like high risk cancer diagnosis. And so we really do take care of full scope gynecologic care. Kimberly Sprague couldn't be with us tonight either, but she is primarily in the Muscatine clinic. She's another one of the midwives that do colposcopy. Lastasia Coleman is working evening clinic tonight, and so she couldn't be with us.
Amber, I'm here.
Oh, yay!
Yeah,
Hi.
I just am in between patients right now, so I thought I'd jump on really
Thank
quick
you.
and introduce myself. Hi, everyone. Sorry, we got situated right next to the kids' flu shot clinic tonight, so sorry if you hear some sounds in the background. But I'm Lastasia Coleman. I have been a midwife for like almost 12 years now. And my favorite part of being a midwife right now is working with our midwifery students. And much like Bree and Amber have mentioned, just like passing on our midwifery knowledge and experience to the next generation of midwives has been a really rewarding part of my job. As far as patient care and things go, I think birth is still my favorite thing. Catching babies, being with people during really important moments of their life, and people trusting us with that responsibility is always something that I think all of us can say we definitely honor and, look forward to every time we're on call.
Mm-hmm. Thanks, Lastasia. Laura Delos.
Hey, I have been a midwife since 1991, and I've been at the University of Iowa for the last 18 years. And I will echo the sentiments of my amazing colleagues and say that, there's um, just everything in my job is what keeps me coming back for more. And I joke and say the day that I do two births that are exactly one like the other, and I can say, oh, I've had that exact one before, I'll quit. And I don't think that's ever going to happen. So I guess I'm going to be doing this a while longer. But sometimes people think that all midwives do is um, things related to birth, prenatal care, maybe some family planning. But in fact, you've already heard that some of us do colposcopy. And because I've been here for a little while and I continue to take care of women throughout their lifespan, a lot of the folks I delivered early on here suddenly started becoming perimenopausal. So this past year, I went back and got certified in menopause, perimenopause, and menopause care, and have added that service line on for our patients as well. So probably not where most of you on this call are at right now in your lives, but to know that if you have that is something we also offer here at the university.
Thanks, Laura. Such a valuable service. Laura Hannabergen.
Hi, I am the other Laura, and I've been with the university for about a year. I started midwifery, graduating from the University of Washington in 2011, and I started out my career as a midwife doing out-of-hospital birth. I am passionate about birth choices, breastfeeding, and I'm also a psychiatric nurse practitioner, so I get to work in that realm through the Women's Wellness Clinic as well.
Thank you. And then I don't think Megan Dre could join us tonight. I think she's in between LDR shifts. And I know that there's an internet outage right now, and so I don't think Meredith could join because of that. Sarah Jones couldn't join, but one of our newest midwives, Sophia Namazi's on. So you want to introduce yourself, Sophia?
Hello everyone. My name is Sophia Namazi. I just joined the university. Being a midwife, can't believe a year now. But I was working in private clinic, now came to the university, and one of the things that I really am passionate about is trauma-informed care, especially with women, and that's one of my passionate things.
Thank you, Sophia. So important. And then next, I get the pleasure of introducing Mary Jansen. She comes to us tonight to just give us a brief little talk about childcare resources. And she brought a couple of her colleagues along too that, Mary, I'll let you introduce if that's okay.
Yeah, definitely. Hi, everyone. Thank you for taking time and listening to us tonight. We are here to talk everything childcare to you. So if any of you are interested in opening up a center or a home tonight, we're here for you. But primarily, we want to talk to you about families and those that you are serving. I brought two of my colleagues with me tonight. Esther is up in the corner, or right next to me, I should say. I'm not sure where she is on your screen. And then Amanda Lady. Esty is our community development specialist for our region, and I'll talk about how we're placed across the state in a bit. And then Amanda is our statewide parent service coordinator, which is really the service we're going to talk a lot about in our time tonight. If you have ever heard of Iowa Child Care Resource and Referral, we're a state agency that serves child cares. We are what I call the in between the state and the provider. So anytime a licensed or a regulated provider needs service, we are that person that comes in, provides technical assistance, we provide consultation, professional development, a little bit of everything. We get them ready and also help them serve and provide quality child care. The other part of our service is parent services, which is in our office. We hold the statewide office that just transferred to us in July. And we had a new dashboard released, and that's when Amber texted me and said, tell me more about this. And I said, I was going to text you. Can I get in front of your colleagues sometime? Because we have some ideas and how we can get in front of parents. So Parent Services is a free service for all families in the state when they're looking for childcare. So number one, we have a parent service office that Amanda oversees with 2 specialists that take phone calls from families looking for childcare. We have a magical database that populates vacancies, updates, rates, locations of all providers in the state of Iowa that are regulated. And by that, it is a licensed childcare center, a registered home, a licensed preschool, or a Department of Ed preschool as well. Depends on the care that they're looking for. We also house childcare homes that are caring for children on state assistance. So if they're receiving state assistance in that home, we also provide those providers as well. We do not house any data for any childcare home that is not registered. So we don't track them at all because they're not accepting state dollars or they're not regulated by the state. But this service is an amazing service for families. So part of our reason for stopping in tonight is really to talk to you about how can we get information in front of your patients that you're serving. We, in August, probably late August, early September, released a dashboard across the state. It was part of the governor's task force where we knew we needed more resources for families besides our parent service specialists. And we knew that we needed something that was at your fingertips, not necessarily a phone call, right? Or a walk-in clinic. So we developed a dashboard, and we're going to send you the link for that in a little bit, depending on how much time we have. But the one thing that dashboard does is it allows you to do a childcare search. So it allows you to enter your home address. So if Amber is entering her home address and needs care for her sweet kids and she's traveling into Iowa City, she can enter both addresses and a map will populate that will show providers along the way that have vacancies. She can then click on Mary's childcare because maybe that looks like a location that would be along her route that would be easy. Click on it, see the qualifications of Mary's childcare, see what vacancies she has, and be able to see all of the contact information to contact Mary to set up some time to talk to her more. I'm going to have Amanda talk a little bit about the flyer that we just created, but that's what we want to talk to you guys about tonight. Is there any potential for us to send you flyers and those to be placed in the hands of moms that you're seeing? Those that are either just finding out that they're expecting, maybe they're getting close to delivering, or even thinking about childcare or children. Because what we know is, as you know, childcare is tough to find, and there's amazing resources out there for families. Amanda, do you want to talk quick about the flyer, and then we'll take any questions?
Yes, I would love to. I wanted to first say you guys are all amazing. I'm so impressed with the work that you're doing, and I just love listening to everyone's story and how you're helping women and taking care of them. So thank you for all you do. We want to help take care of families in Iowa too. So that's why we made a new flyer. Mary, if you want to share that, so everybody can see it. Like she said, we just kind of want to get childcare on everybody's radar. So whether they're brand new parents or thinking about kids, or they have kids and they're going back to work, the process can be lengthy and it can be overwhelming. So we're here to help guide everybody through it. Like she said, they can call us at the referral line, and we're happy to do the legwork for families. We'll filter it by whatever their specific wants and needs are. So it could be location, languages spoken, accepting state assistance, all that good stuff. We can kind of narrow it down so that they're not so overwhelmed. We love getting calls. We would like more. Like Mary said, we took over in July. So We want people to call us all the time. Let's see.
Sorry, I don't have permission to share, so I'm getting it sent to Sophia.
Gotcha. Okay.
Sorry for
No
the
problem.
delay.
That's all right. I'll just keep talking. So like she said, we've got two great specialists that take the phone calls. They're really great at just finding hopefully the right fit for your families. Once we send the referrals, it's the family's job to contact their providers. We send along with that a list of good quality indicators to look for, good questions to ask the providers so that they kind of are feeling everybody out and making sure that it's not only what's available, but what is the right fit for them. So here's our lovely flyer. That top part there has our phone number that'll get you to an actual human that'll help you through that process. And then over to the right is the QR code to the dashboards that Mary spoke of. Sometimes people don't have time to call or they don't want to call. They can just run that search themselves. All that information is right there at their fingertips as well. They can see, compliances with the state, complaints. They can see if those providers have openings, if they're on the route to work, like she's talked about. Another focus that we had was just letting parents know what their options were. Not everybody knows, the different types of care. So down below on the bottom part there, we have it broken down into 4 little sections. The one at the very bottom is what Mary talked about, where there's no state dollars being funded. They're not really regulated. Everything else, it has different varying levels of education, like continuing education hours needed, background checks, certain trainings that are required. And then there's going to be different levels to the extent of which Health and Human Services involved, whether that's inspections for regulations or accepting that state funding or things like that. So we would love to get this in front of as many parents as possible in Iowa.
Definitely. So I think our other question, any questions from all of you, and then also any follow-up or anything that we can help for next steps.
I think that people have to type in questions because only the panelists can talk, but we can definitely wait for those. I will say this is a super easy process, and this new app is even fancier than the dashboard is even fancier than the one that I used when we moved actually to Iowa City 5 years ago, and we utilized these services to find care here, and it is slick, you guys. So daycare is hard, especially in our area. And this is a free service, right?
Definitely. Yes.
So I think what we'll do is we'll just, Mary, like I said, if you can forward this to maybe me and then also Sophia, and I will get these handed out to our staff so that we have them in the clinic. And then also Sophia will hand them out or send them out to everybody that registered for this webinar too.
Mm-hmm. Yeah, that'd be awesome. We also have posters available as well. So this would turn into a poster if you ever wanted to hang it in the clinics. Just let us know. If you also have events, I know last week Amanda was down at a health fair at U of I as well. But if you have events that you want us at, let us know as well. We're happy to pop down and talk to families in person as well.
Yeah, keep you in mind for sure. Awesome. All right. Well, thank you guys so much for joining. I appreciate you. Yeah. Have a good night.
Thanks. We'll see you soon.
See you soon.
Bye.
All right, everyone. So next, I am going to go ahead and share my screen, and Bree Herring's going to, we're moving forward to the next part of our webinar that we have a few different topics that we like to cover with every webinar. And then rest assured, we'll get to your pre-submitted questions. But please feel free in the Q&A to ask all the questions that you'd like, and we will either answer them live or type in a response for you. So I'm going to go ahead and share my screen, and Bree will talk through making a birth plan, or what we like to refer to as the pregnancy roadmap. Can you see my screen, Bree?
Yeah, my eyes are just the same age that I am, so I gotta zoom. So we like to give our patients this pregnancy and birth roadmap, typically kind of early on in the third trimester. A lot of our patients do create some type of a birth plan either on their own or perhaps with a doula or birth attendant. But this is kind of our University of Iowa midwifery group roadmap. We call it a roadmap because as much as we would love to plan everything that goes into having a baby, most of us have been around the block a couple of times and realize that planning and a birth experience aren't always words that go quite hand in hand. So on the front page, there are a couple of goals that people can set for pregnancy, but especially later in pregnancy, ways to stay healthy, some nutrition goals, maybe some activity goals, some, maybe set a goal of learning a little bit more about pregnancy, learning about the birth experience. And then there are a couple more pages where we have, if you can scroll, Amber, to the second one. So this first page here, I guess the second page of the plan would be just what somebody is thinking. I always explain it to people as like in a completely ideal world, you just go into labor, you're having a healthy baby, everything looks normal. What would you want? What would that look like? So would your goals be sign me up for some type of pharmacologic pain management the minute I hit the door? I want to know that about you. If your goals are going to be to kind of try all the things that can be tried before moving into something that's more medication based, I also want to know that. As mentioned, we are a really large group. And so at my previous practice, it would be pretty rare for me to have somebody in labor that I hadn't at least met once and probably seen several times. But here it's pretty common that I might come in and meet you for the first time and sit down and chat with you when you come in to have your baby. So just some ideas of the things that we have available on labor and delivery. We have this massive closet full of different types of birth balls and peanut balls. Midwives are huge fans of position changes. So many of our nurses and all of our midwives are trained in something called spinning babies, which is something that people can do at home, either in early labor or even through that third trimester of pregnancy to help baby get in a good position for birth. But also has a lot of different positions available in something like a little laminated card that you can look at on labor and delivery to try different positions based on what we think your kiddo is doing inside of you. Heat and cold can be super helpful. Music, a lot of people will bring lights from home, like little battery tea candles from home, a playlist with comfortable music. All those kinds of things can be really helpful for making somebody feel more relaxed and calm in labor. And then in our labor and delivery rooms, we also have tubs that people can use for hydrotherapy, which can definitely help with pain and help labor progress as well. And then, of course, the more traditional things that lots of people have heard of, like IV pain medication and epidural placement. For a lot of our patients that are healthy and low risk, they can also pick between monitoring their baby consistently or continuously during labor and monitoring the baby intermittently, where the nurse is just using a little handheld Doppler to listen to baby here and there. Sometimes those aren't appropriate, or it might not be appropriate to do intermittent monitoring based on health status, but that would be something that your midwife would talk to you about at the time. But we always want to know ahead of time which your preference would be if everything is going well. And then as far as care team, I think most people who come to the university know that we have a lot of different types of learners. So we have learners, we could have nursing students or medical students. We could have residents who are OB or who are physicians who have completed medical school and are working on the obstetric part of their training. And then we also have a handful of really fantastic midwifery students who are all experienced labor and delivery nurses that are really excited to participate in your care. So some people are okay with any or all learners in their birth, and some people would prefer to keep the group a little bit smaller, or maybe have a preference that the only learners are ones who are actually helping with the birth and not there for observation. What's next? So we kind of talked through for most patients, if you're healthy and having a healthy baby, our goals are kind of to just support the physiologic experience. So a lot of partners are really helpful and volunteer to like turn all the lights in the room on for me. And I'm like, we don't need to do that. We can just have like dim lighting, calm environment. We don't intervene if there's not a reason to intervene. So up until about a year ago, I could actually say I'd never performed an episiotomy in my entire career. Now I have performed one. So I always tell people if you're like number 2 out of over 1,000, then we'll both need a little bit of therapy after perhaps. But this is an opportunity for us to kind of talk through a few things that would be really common or expected with a low risk, healthy midwife birth, and then some things that could potentially be needed if something more exciting is going on. So in a perfect world where we have a normal labor, normal pushing phase, healthy baby, typically we would bring baby straight to chest. We want you to do skin to skin really for that first hour if possible. We're big fans of that golden hour, helping baby get acquainted with the parents and figure out life and breastfeeding if that's your goal. We typically all do delayed cord clamping. And then again, like I said, if something extra is needed in that time frame, your midwife and your care team should kind of be able to explain to you why we don't think that doing skin to skin is the best idea. A lot of times parents can even tell the baby might need just a little bit of extra help, or we need to go move over to the warmer to get baby a little bit more perked up. And then obviously, if you're seeing the midwife group, for most people, your goal is a healthy vaginal birth, but sometimes we know that a C-section birth could be the safest way for your baby to emerge and meet you. In that case, you could mark down if you have any special requests, and we could definitely try to accommodate those during a C-section. And then, of course, I think we spend a lot of time during your pregnancy talking about having the baby, but you also are then, after the baby is out, going to kind of transition into being a parent of baby. So what do you bottle feed? We try to talk through those medications that we recommend in the first hour or so after your baby is born, to help decrease things like infections in the eyes, and the chance of your baby having some type of a bleeding problem. Can you guys still hear me? It says my internet is unstable, whatever that means. Yes, I can see you all.
Yeah, it was a little choppy
okay,
for a minute, but you're good now.
Okay. So this is a good opportunity ahead of time for you to talk through what these couple of recommended things that we do for baby in that first hour, just so that you have a good understanding. And then also a little bit of information about when you might want to go home. For some people who have a really healthy, low risk, kind of not anything exciting or out of the ordinary experience, a lot of people do pick to go home at the 24-hour mark, where they can kind of start. I always felt like when I had my babies, that time in the hospital wasn't like real, and I was just ready to go home and get like real life with my baby started at my house. So we definitely encourage that if you feel ready to go, you feel like all your education needs have been met, you feel like your baby's feeding well, the baby's team have no concerns, we have no concerns, going home at 24 hours can be really nice. For some people, breastfeeding might be a little bit more rocky, or their birth was a little bit more challenging. They might need a little bit more time in the hospital. And certainly some people do really need that full 2 days with a little bit of support from the medical team. And then at a few different spots in this plan, you've probably seen those boxes. Some people have special requests or preferences, things that they've read about, things that they're interested in. I always recommend writing down anything that you think might be important for you at the time of birth, because I always think that some people who have an experience that wasn't what they expect, it can be not that anything bad happened, but that their expectations weren't managed well. So if you write down the things that you're hoping will happen, it gives a really good opportunity for your midwife team to talk to you ahead of time. And sometimes people put things down on there that I know will be either difficult to achieve or perhaps impossible. Like sometimes people write down that they want nitrous oxide in labor. The university doesn't have that. And so being able to tell you that ahead of time and kind of talk through alternative management plans for your pain can be helpful, versus showing up at the time and hoping that something will be available and it's not. So this birth plan or birth roadmap is really nice just for helping people who might not know you very well from your prenatal care to get a good idea of what you're expecting, and then for you to kind of write down the things you're hoping for. So hopefully we're all on the same page when you come in to have a baby.
Thank you so much, Bree. Stop sharing my screen here. Okay. And then next, Laura Hannah Bergen, would you mind briefly talking to us about the role of learners in labor and delivery?
Sure. First, I'll just echo the things that Bree said. She kind of went over just the potential types of learners, which are nursing students, medical students, residents, and midwifery students. Right now, the most common learner we have in the room is midwifery students, because we have their program underway, and they most people love having them there, because it's like having another birth attendant there who's very knowledgeable and is going to help support them in like birth positions and with their management of their birth. And just so you know, it's always your choice who's at your birth. You know, this is your birth, not an opportunity for everyone around you to learn. But sometimes having someone that just observes is not intrusive. That's okay. We don't usually recommend you having more than one learner at your birth. So if you have a midwifery student, it's not, you don't need to feel obligated to have more people there. The residents, like Bree said, are physicians who are specializing in obstetrics, and they often are involved in your care if things become complicated. So like if we need to consult or if we need to refer you for an operative birth because something is not going well, you may communicate with them, and they are wonderful. They are very supportive of the midwifery model, and they believe in the things we do. And so most people don't object to having other people like that involved in their birth.
Thank you so much. That was a beautiful way of putting it, Laura. Becky, could you talk a little bit about what sets us apart?
Yes, I can. So the thing that I think that really makes sets midwives apart is that all of the education that we provide throughout prenatal care, we want to make sure that people have the information that they need to make informed decisions about their care. And so starting with the first visit, when people are finding out that they're pregnant, we start with educational information. And at every visit, we give a little bit more information to women. We don't try to get it all in at once. It would be overwhelming. And so over the course of the 13 or 14 prenatal visits that most women have, we will give a little bit more information at each visit. And once women have the information about how to have a healthy pregnancy, that allows them to make informed decisions about how they want their care to be. And we use something called shared decision making when we make recommendations and give them information, and we discuss the information that we've given them. And then the patient is allowed to make their own decision. It may not be the same decision that we would make, but it's the decision that the mother is allowed to make, and we still support them in whatever decision that they make. We also believe that pregnancy and birth is a really normal and natural process. Bodies are designed to do this, and as long as there are no medical problems that are developing, we allow pregnancy and labor and birth to kind of happen on their own. We don't believe in unnecessary interventions if there's not a really compelling medical reason to intervene. And so we allow women to go into labor on their own as often as we can, because we believe that is the safest thing for them to do. And we also feel like that the more interventions that we have, the more risks that we are exposing patients to. And so we believe in the process of normal physiologic birth, and we let it happen. So we don't routinely do elective inductions of labor because someone has a specific date that they like, or because it would be convenient for us. I mean, we all get very attached to the patients that we see week after week, and we develop quite the rapport with them, and we'd love to be able to be the one that catches their baby, but it's not worth exposing them to more risk by trying to induce them before their body is ready. And so we allow things to happen on their own. And that's probably the biggest thing, is that we don't intervene unless there's medically a reason to. And then we support the patient throughout their pregnancy and their birth.
Thank you so much, Becky. Next, Laura Delos, will you tell us what is our policy on postpartum pregnancies and inductions? new phone problems, right, Laura?
There we go. Sorry about that. Lots of phone stuff this weekend with brand new phones at our house. So the question was about inductions. Is that
Yes.
right?
What is your policy on post-term pregnancies and inductions?
Sure. So, thankfully, most pregnancies proceed along a very healthy path, and the placenta works very well for women who don't smoke and are otherwise healthy up through the 39th week, and into the 40th week. At 41 weeks, we do recommend that if someone wants to continue with their pregnancy past that time, so that's 1 week past the due date, that we suggest that someone would have some testing done where they have an ultrasound and what's called a non-stress test, which is a short little burst of fetal monitoring for about 20 to 40 minutes. If all of that looks okay, then if someone wants to wait, we would wait with them through that next week, but would encourage delivery by the 42nd week, because it's after that time that the stillbirth rate does begin to climb in a way that we feel it's better to have a baby out rather than in. As an aside, the due date is really not a highly scientific thing. It was a mathematical calculation done several hundred years ago, when someone was trying to figure out paternity and who needed to like cover that. So when you think about like all these really like, oh, it must be based on all this data, it's sort of is called an estimated due date because it isn't an estimate. And most people having first babies will go past their due date. So about 3 to 8 days. So we really encourage people to wait and have their labor start on their own, because typically then labor goes more efficiently and we reduce many interventions and untoward outcomes that can happen with labor inductions.
I'm so sorry, you guys. My crying toddler just came in my room, so please bear with me. Bree, can you talk to us about pain management techniques during labor?
Yes, and I have no crying toddlers, but my internet is still telling me it's unstable, so I'm really sorry if it cuts out. I don't know what's going on. There are a lot of different pain management techniques that our patients take advantage of. Certainly a lot of people plan to go without some of the more like heavy hitting things like an epidural. And I think one of the best things that you can do if your goal is to go kind of with like that more physiologic experience would just be read everything you can, not like on TikTok, but like in a book, or on like a good website. Really learn about the labor process, because it seems that people who are really prepared and kind of know what to expect in their labor are a lot more likely to kind of accomplish those goals, because when they experience sensations that they weren't expecting or haven't experienced before, they kind of were expecting that. So instead of triggering that kind of anxiety and fear that can come along with labor, people feel a little bit more empowered. Like, okay, I remember reading that I was going to get really shaky. I remember reading that I was going to feel really nauseated, like I might vomit. So it's kind of like that little part of your brain that remembers reading that can tell you, okay, this is fine. This is normal. We were ready for this. We were expecting this. So I think preparation is a big part of kind of going into the pain management part of labor. Once you're actually in labor, we have quite a few different things that we can offer. So we have all the kind of non-pharmacologic labor support tools at our disposal. We have the tubs, or at least a shower in every single patient labor room. We have a lot of people who come in prepared, like I said, with some type of like music track or some sort of like meditation type track on their phone that can kind of help them deal with those contractions. Some people, it seems now, are really using the comb. So I don't know if you've seen any videos of that online, but a lot of people have that comb and can kind of like squeeze it for that distraction technique or something to focus on during the contractions. We have lots of different labor positioning tools. So we have the birthing balls that people might want to bounce around on, the peanut balls that we can use either in the bed when somebody is just trying to find a way to get comfy and rest for a little while, or perhaps after an epidural. And then we also have the cub positioner, which is kind of like this horseshoe shaped inflated tool. You can Google it and see it, but it's really nice because we can help people get in a lot of different positions. I think some people are really prepared for the physical work of labor, but forget how tired working really hard for a long time can make you. So having all these different tools are really nice because it kind of can help you position your body in a way that's more comfortable while you do the work of those contractions. If you kind of progress through all those non-pharmacologic options and feel like you need something a little bit more, or from the beginning, if you just decide that you want something a little bit stronger, we do have a couple different options for IV pain medicine. Those are really nice for taking the edge off the pain of the contractions, but still allowing you to kind of reposition, move, get up, and not feel like you're kind of stuck in bed or feel like your legs are heavy. Sometimes that sensation of not being able to feel your legs freaks people out a little bit. So it's nice if you know you need a little something, but don't want to quite progress to the epidural. And then, as mentioned before, we definitely have a large number of patients who pick to do an epidural. With the epidural, the disadvantage is that you're stuck in bed, but the advantage is that you might be able to get a little bit of a nap, kind of have a mental reset, or certainly for somebody with a longer labor, it can definitely allow you to have your body do that work while your brain is able to take a little bit of a break from it. So lots and lots of different options. And then, as I mentioned before, when talking about the roadmap, a lot of people in-house are trained in those spinning babies maneuvers, which can be done both before an epidural or after an epidural. So if you do choose to get an epidural, your labor team are going to work really hard to try to keep your body kind of moving through all those steps.
Thank you, Bree. Bree also loves to teach, in case you didn't notice. Elizabeth, can you tell us, how do you support a VBAC attempt differently than other providers?
I think piggybacking on a lot of what has already been said, that we are huge proponents of the physiologic process of labor and delivery as much as possible. Our goal with that VBAC experience is to help facilitate that just as much as we would a non-VBAC labor, especially hoping and trying for labor to start on its own. That is going to be one of the biggest things for having a potentially successful VBAC experience. So with our VBAC moms, we do want to watch that baby a little bit more closely, a mom a little bit more closely. So we do like to have the monitor on to watch the baby the entire time, but we do have the wireless monitor so that you can still be up and moving around and utilizing the balls and the cubs and the shower and the tub and walking around, and we can still keep close tabs on mom and baby. You can still eat and drink in labor. You can still do all the different positions, the skin to skin, all the things. We just watch a little bit more closely, and we would follow the same recommendations as far as monitoring for any issues with blood pressure or blood sugars or anything during the course of pregnancy. But as much as possible, our goal is to support you and your decisions and how you would like your VBAC to go. If that's what you would like to do, knowing the risks, the benefits, the alternatives, and what might be safest based on your history and what you would like, but to facilitate the physiologic process as much as possible.
Thank you so much, Elizabeth. If I may just piggyback off of that, we work really, we consider ourselves a team with the obstetricians, the OBGYNs that are with us. And so we like to have the idea of being able to offer folks vaginal birth after cesarean and what feels like more of like a homey environment with a midwife, but with the safety of having a physician there if a complication were to arise. And I think we're really lucky to have very supportive obstetricians at our facility. In fact, we trained quite a few of them because the midwives help to train the first and second year residents and have been able to watch them go through an honor birth as well. Laura Hannah Bergen, if a big baby is suspected, do you alter care? Is the next question.
Yeah. Good question. So as midwives, we trust birth, and we trust that people are going to make babies that are appropriate for their size. And so, and we also know that when we measure the size of a baby, our tools are tremendously inaccurate, or they can be. They're not always based on complete science. Like an ultrasound could say a baby is going to be very large, and then we've all seen a baby come out and be like, "Oh, this baby's a completely normal size." So the size of a baby is not the only factor we're considering when we're looking at someone who's planning for their birth. If we know that someone also has like gestational diabetes or there's other factors, we might talk about the risk of shoulder dystocia, just kind of counsel you on that. But as far as like treating you and your labor differently, unless you prove to us that there's something wrong, we're going to trust that your birth and your body know how to make the appropriate size baby, and that and then we'll work together to work out a safe plan to make sure that things go well for your birth.
Thank you, Laura. The next question that we have is for Sophia. Do you have tubs available or water birth and offer fetal monitoring where you are not connected all the time?
We do have tabs at the university. Right now, we don't have big tabs at the downtown campus, but you could still use the shower and all that. With the fetal monitoring, we have what we call the wireless ones or the external ones, whereby you can go in the tab with them, and you are able to move around as needed. The only thing is we don't deliver in the tabs, but you can labor in there for pain management.
We actually do have tubs downtown.
Yeah.
Yeah, we do.
They're not the sort of, our ones at the university are sort of 2-person tubs, and the ones at the downtown campus are kind of a more traditional bathtub size, but they do have them in their rooms.
I'm sorry, my toddler. Oh my goodness. Laura Delos, I thought this was a good question for you because she's so motherly to me and really been a great mentor for me too. What advice do you give to mothers that are absolutely terrified of birth?
So I think be a little bit selective about who you talk to find those people in your life who have had birth and who you trust, and know that the general public, says all sorts of crazy things to people when they're pregnant, completely unsolicited. And sometimes when people say to me, well, so my family's saying this or someone's saying this, I say, well, just say my midwife is telling me this. And that oftentimes will help those sort of naysayers or negative Nellies that are in their lives. I think there is a certain healthy level of fear that brings us in to get prenatal care and seek people to have around us to support us and guide us through things we do in our life that are scary for us. It makes us put a seatbelt on when we get in the car. So really thinking through what are the things I'm worried about. Talk to us about those things. Make sure that, they're not just things that maybe people have told you that don't even happen or aren't really things that we would be concerned about for you. And know that there are all sorts of tools and things we can do to help support you through the process, but there is no such thing as a painless birth. It's called labor because it's hard work. But like many of my partners have already said, our bodies are really designed to do this. And when we trust in that, and we can let our bodies work in the way they can and not work against our bodies and let go of some of that fear, things tend to roll along in a pretty predictable fashion in birth.
Thank you, Laura. I'd echo that, just like really trusting your body. And even if it starts with some words of affirmation that you have written down on a postcard to read to yourself every day. Like, I am strong, I am capable, my body will grow the perfect baby. I think that's super helpful for folks.
Yeah, thanks for bringing that up, Amber. I think a really, really great thing to do is get whoever's going to be with you at your birth and just get a pad of yellow sticky notes and each take some sticky notes and have some fun with it. Write some silly things that'll make you giggle, but also put down some of those statements and just put them around. Stick one where you're going to brush your teeth, put one in your car, put one in your closet. Bring them in when you're in labor. That just are those reminders and things to put deep down in here. Because I'll tell you what, when the going gets hard in labor, you will have someone on this shoulder saying, a voice that may be telling you you can't do it. But if you've been telling yourself all these positive messages, it's a lot easier for your birth team to pull those out and to support you through and use those same words. So I think that's really important.
And if we couldn't do this, we wouldn't be doing it. There would never be more than one child born in a family because we know how to prevent pregnancy, but we keep having babies because it's not as bad as you think it's going to be.
I think there's a really good question in the chat. If I could get one of the midwives to volunteer to answer it for me. Will the midwife be the primary person in the room working with me throughout labor up until the end? During my last birth, it was mostly nurses helping me through the process with the OB-doc coming in at the end to catch the baby. How is the midwife model different?
I would say that I think we will really, as best we can, try and support you in the way that you need. I just had someone who her birth plan said, I don't want people hovering. My partner and I want to be really left alone. And sometimes that's hard for us, right? So, but we really we honored that and really gave them that space. Conversely, if you're at that moment of birth where you really need us and need our hands on and need our help, then we will do our best to be in there and help you through. And if we get pulled into another birth, then we're going to be talking with your nurse about, here's what's in the birth plan and working together again as that birth team to help you. But with us being as hands-on as we hopefully can be to help you through. It's another great reason that it can be wonderful to have a midwife student there because it's another really seasoned person to provide that support.
I echo that. Okay.
I think, oh, am I working?
No, go ahead. Sorry.
Oh, I was going to say, I think most of us became midwives because we really love supporting people in labor and being able to have that. I mean, the number of people I've sat with for hours through transition, I can't even count at this point in my career, but at the same time, I understand our limitations and our limitations of our system. So we work in a facility that sometimes you could be my only person in labor. And I've also had 7 people in labor. So if you know that for you, having a trusted person that you've met ahead of time as a birth companion who's only there to support you, if you know that that's really important to you, I really encourage people to look into getting a doula. There are some insurance programs that support that, some county level programs that support that. But that, I'm sorry, Amber, I'm cracking up at your little one.
I'm so sorry.
It's super cute. But I think it's really important to know that your midwife would love to be there if possible, and it might not be possible to kind of do that really intense labor support. So our nurses are also fantastic. The nurses, I kind of joke, / not joke, are the star of the show. They're in your room a lot. They're able to suggest lots of different things for you, but truly, if you know that for you, that one-on-one dedicated support that will only be responsible for you is important. A doula can be a really great resource as well.
Totally agree. I really enjoy being with my patients the whole time they're pushing, the whole time they're transitioning, especially if they're unmedicated. But just like Bree said, sometimes we have multiple people in labor and we physically can't. But we do really pride ourselves on trying to be there often. All right, you guys, I think that we've got all of the questions answered. And I want to thank everybody so much for coming out tonight and learning more about midwifery at Iowa. The facilitators will send out a follow-up email that has our pregnancy roadmap plus the information about Iowa childcare resources on it. And until next time, we hope you all have a great evening, and please let us know if you have any questions.